And we have a third part to this Fitzpatrick and skin color tone trio, and we want to have Anisha Bhanot come on, and she is one of our University of Oklahoma fourth-year medical students here of Edmond, Oklahoma. She is an undergraduate degree at the University of Central Oklahoma, and she has interest in skin of color as well as serving members of the underserved community. And she is an aspiring dermatologist in the making, and she has collaborated with me as well as a few others on a study, and she is going to present that to us now. Fitzpatrick skin type, self-reporting versus provider reporting, the OU experience. Thank you, Anisha.
Thank you. So let me just share my screen. Okay, are you able to see my PowerPoint without the notes? Okay, good. So thank you so much for the introduction, Dr. Allen. As she said, my name is Anisha Bhanot. I'm a fourth-year medical student here at OU. And today I will be presenting to you all about Fitzpatrick skin type, self-reporting versus provider reporting. And this research project was done in collaboration with Dr. Allen, Dr. Sally, and Jamal J. Besu. Okay. I have no disclosures to give today. And for objectives, so today we will be covering certain objectives. In today's talk, we will be explaining the designed intention and methods of the Fitzpatrick skin type research project, summarizing the results of Fitzpatrick skin type reporting between provider, trainee, and self-reporting, and also discussing the implications of the discordance of Fitzpatrick skin type reporting between these groups. And a practice gap we would like to cover in today's talk is that there is a lack of concordance when it comes to classifying patients' Fitzpatrick skin types amongst providers, trainees, and patient self-reporting. And this lack of agreement can influence clinical practice and management. So for the experimental design of our study, we had a survey-based study, and this survey was offered to all adult patients 18 years and older, along with dermatology residents and faculty providers here at OU Health Physicians Dermatology Clinic in Oklahoma City. First, a consent was obtained from our patients, and we collected about 500 patient surveys over the span of 18 months. The data was then entered along with the Fitzpatrick skin type that was assigned to the patient at that day of the visit. A provider survey was also administered to our dermatology residents and faculty providers, and the data was de-identified and a biostatistician analysis was performed on the data. This is a copy here of our patient survey. As you can see, we had 7 questions. The first question really entails the patient's ability to burn and tan. And the second question here is the patient's reaction to sun exposure in terms of redness, irritation, tenderness, itching, and skin darkening. Questions 3 to 5 were demographic information questions. Question 6A was the patient's reported ability to sunburn. 6B was the patient's reported ability to tan. And 7 is the patient's untanned skin tone. And here is a copy of our provider survey. So many of the questions were overlapping, but we did also ask the provider's level of training, along with how many years they've been in practice, along with the provider's own Fitzpatrick skin type. And lastly, here in question 11, we asked how the provider determines the Fitzpatrick skin type of the patient. Okay, so here is a pie chart showing us a little bit about our patient population. So we had a large amount of female population filling out the survey, along with male and even trans patients. And here you can see on the right, we have a bar graph of the patient age distribution, and we have quite a broad distribution in our age. groups. And here is another pie graph showing the ethnicity of our patient population. So we have a very well-diverse patient population here at OU, and that can be seen in this pie graph. As you can see, about 2/3 of the patient population is white, followed by Black, Asian Indian, Latino, and even Native American population. So for our provider characteristics, about more than half of our providers here at OU are female, and more than half of our population, the provider population, are in the resident training years, and that can be denoted here with 0 years in practice, and also on this pie graph here with our level of training, 55% being resident population, 35% being dermatology providers, and 10% being advanced practice providers. And here we have another pie chart showing the ethnicity of our providers. So 85% are Caucasian, followed by 15% either Hispanic, Black, or Asian Indian. Okay, so now moving on for our results of our study, we found that there were significant differences between provider assigned Fitzpatrick skin type and answers to questions provided by participants. The average patient rating for tanning versus burning was 0.51 points higher than the mean Fitzpatrick skin type for the sample. So patients did underestimate sunburns in relation to ability to tan and the skin tone of untanned skin. And this has been something that's been well documented historically in literature. Moreover, we found that the provider assigned Fitzpatrick skin type was actually more accurate than the patient's own estimation of their ability to tan versus burn. And the patient underestimated redness, irritation, tenderness, and itching, but not skin color change. When looking at demographic characteristics of patients and the likelihood of discordance between provider-assigned Fitzpatrick skin type and patient perception of tanning versus burning, we found that being of Latin origin was actually heavily protective against a discrepancy with an odds ratio of 0.262. On the other hand, being white or Asian Indian had a higher odds of a discrepancy with an odds ratio of 1.359 and 1.623 respectively. Interestingly enough, none of the demographic characteristics of the provider were actually significant in predicting a discrepancy between provider and patient assigned Fitzpatrick skin type. Now, when looking at demographic characteristics of patients and the likelihood of discordance among provider-assigned Fitzpatrick skin type, patient perception of tanning versus burning, and patient estimation of Fitzpatrick skin type, we found that patients that identified as Black, that was heavily protective against an existence of a discrepancy with an odds ratio of 0.18. However, patients who identified as white had a higher odds of having a discrepancy with an odds ratio of 1.8. And interestingly, being Latin was still strongly protective against a discrepancy, but ended up losing significance. Now for provider results. When we're looking at any discrepancy between provider assigned Fitzpatrick skin type, patient perception of tanning versus burning, and patient estimation of Fitzpatrick skin type, we found that actually more provider years in practice increased the odds of any discrepancy existing. However, provider characteristics such as age, gender, or their own personal Fitzpatrick skin type were not significant in predicting the odds of any discrepancy existing. Now, this is a forest plot, just summarizing up the results that were in the previous two slides. As you can see over here, more provider years were associated with a higher odds ratio. And here, being of white race was also associated with higher odds ratio. And being of African-American race was seemed to be more protective from any discrepancy. So in summary, patients underestimated redness, irritation, tenderness, itching, and sunburns relative to untanned skin tone and ability to tan. The provider assigned Fitzpatrick's skin type was more accurate than the patient's own estimation of their ability to tan versus burn. And patients who identified as Latino or Hispanic or Black or African American were protected against a discrepancy, versus the odds of having a discrepancy were actually higher among whites and Asian Indians. In addition, more provider years in practice increased the odds of any discrepancy existing. But provider age, gender, personal Fitzpatrick skin type were not significant in predicting the odds of any Fitzpatrick skin type discrepancy. So looking at the clinical and practical implications of our data, we can summarize that patients do not accurately identify their own Fitzpatrick skin types. And Fitzpatrick skin type classification is an important part in providing expert care for all skin tones, such as when we're providing patients with light therapy, sun protection counseling, cosmetic procedures, aging education. However, just as Dr. Taylor mentioned, it's not a perfect system and needs to be looked at in terms of better concordance. And patient education definitely does play a big role in this. These are my references. And that is it for my presentation.
Thank you, Anisha. You did a great job. Do you have any key points that you'd like to highlight that made the most of an impact on you while you were doing the study? I know you were a really big part of it, so congratulations.
Yes. Thank you so much. So, just being part of such a important project, especially in the skin of color community, has been a great, importance to me, and getting to learn this data and seeing it from the student's point of view and being able to translate it and how I'll be using this as a resident and hopefully as a future practicing dermatologist really, puts things into play for, us trying to provide a more holistic approach to dermatology and better care for our patients. And it just highlights the importance of patient education as well.
Thanks.
Thank you.
Excellent. Any questions or comments? All right. Well, we thank you so much, Anisha. It was wonderful. And we will continue to look at further data as it is even being analyzed, but we plan to publish this as well and continue our research endeavors in this area.